Welcome to the After Hours Clinic with Dr. David Janarious and Better Life co-founder Andrew Lane, where we unpack the science of health and wellness, cut through the noise, and add a healthy dose of humor.
There's been a lot of Ozempic news lately, and I was thinking it's pretty on brand. We got to cover this. I know you sent me one of the articles. I don't know if you feel like chatting about that. And
Yeah, absolutely. It was actually a patient who made me aware of this. And this is like a Vox News article, I believe, that is talking about like, oh, we're finally seeing the Ozempic effect. And it's funny because for the past few years, I've actually been doing that. I've been checking the CDC's website to see if they have like new obesity data, because I was really intrigued to see if there would be a measurable dent in obesity, with the advent of all these, very popular GLP-1 drugs for weight loss. To date, I don't believe there's any new CDC data, but I think this article references Gallup poll data. So it's, self-reporting, which is a limitation. The data seems to point that there actually has been a drop in rates of obesity from the peak of obesity, which I think was like in, mentioned pre-pandemic.
it declined by 3 points, looks like.
Yeah.
So from about 40% to 37%.
And that's from 2022. So that's actually post-pandemic, which makes sense. I think a lot of people, myself included, put on a few pounds during the pandemic. It was like impossible not to.
Yeah.
So 2022 was probably the peak, which makes a lot.
I mean, there was no toilet paper to use, so you had to hold on to that extra weight.
Yeah, it was all just measured in stool weight.
Poop jokes are on brand here.
So this is self-reported. There may be some limitations there, but it does seem to track, and it's a modest decline, obviously. But as we know, when we're talking about populations, 3% is millions of people.
Yeah. In a country of 300 or 400 million people, this is, almost 10 million people we're talking about here.
It's not nothing.
Are no longer obese.
Exactly. It raises all kinds of questions. One, are there any changes in health outcomes that correlate with this drop in obesity? So actually, right underneath, we see the diabetes rate. And if you notice, that actually has remained kind of level since 2022.
Yeah.
And again, that may just be a lagging indicator, meaning if we look a few years later, we may actually start to see the decline.
Yeah.
There's other indicators that I'd be really interested in. This article mentions how there have been studies that have shown, a 20% reduction in major cardiovascular events, so heart attacks, strokes, and death from those causes of about 20%. So it would be interesting to see if we're actually seeing a decline in rates of those conditions that correspond with the drop in obesity.
And it'll be a while before we have the data, right? I mean, it'll.
I think so. That's probably a thing to look into, like when will the CDC be reporting next? And maybe it'd be worth just hopping on the CDC website to see if there's anything new under the sun there.
Maybe one of those self-reporting databases could also be an early indicator of phenomena.
Like which ones?
I don't know. The self-reported databases of it's not VAERS. There's another one for drug effects, right? I forget which one.
Yeah. The FAIR system. Yeah.
Yeah. There's just the outlandish things that get self-reported. Like I started Ozempic and then lost a toe or something.
I'm not seeing any new data, but it's something that we'll check when we're looking offline. But yeah, so it would be, curious to see if there's been a decline in these. And then the other thing would be interesting is to see like what has been the financial cost of all this. Kind of see if like the decline in health outcomes is, basically worth the money spent, just from a purely intellectual perspective, right? Not that I would want to then restrict medications if they didn't. It does beg the questions like, because these medications are uniquely expensive. We've seen evidence that it's putting a strain on system. Recently, you pulled up something from Cigna, right? That was kind of fascinating.
We know the financial burden is huge, right? I mean, the individual cost is that's being billed to insurance companies is somewhere around $1,000 a month, $1,000 a month for each prescription, whether that's Ozempic, Mounjaro, Zepbound, tirzepatide's a little higher. And, I'm a part of a tiny health insurance group, and I'm on tirzepatide, and my insurance is paying for it, fortunately. And they raised our rates 40% this year. I really had to think long and hard about, like, should I ditch them and go with a company that doesn't cover my tirzepatide, because I'm getting $1,000 a month of benefit from that, but my rates are going up tremendously.
Does the increase in rate equal the amount you'd be paying out of pocket?
It was pretty close, honestly. Really? We're a family of four, right? So it's not uncommon for a family of four to have premiums that before you look at either subsidies from the government or what your employer's paying, the raw cost of those plans, it's not unusual to see that in the $2,000+ range. And so when it went up, an extra $1,000 a month, that's
it becomes a wash.
Yeah, incredibly frustrating. We do a whole nother episode on healthcare premiums. Depending on what happens with the longest government shutdown in history, there may be more to say on that soon.
It does beg the question, like, would you ever consider switching to a cheaper plan that doesn't cover weight loss benefits and going with the compounding pharmacies that are still allegedly compounding tirzepatide?
Maybe.
Eli Lilly, if you're watching, they're not.
Right. Yeah, I know. I mean, we know that that's unfortunately a game of whack-a-mole. It's hard to say. I think, we chose to stick with it for another year, but at great cost. I'm hopeful that there'll be some pretty big developments. The Trump administration.
Before we jump there was, and I wanted anything starting with the Trump administration is going to be interesting, so I don't hold that thought. But, we actually got some interesting feedback from some patients who have Cigna insurance that there is kind of a
yes, I'm sorry. Yeah.
Keep, some of these prescriptions. Because Cigna, for those who don't know, their plans, a lot of them do cover these weight loss medications, particularly those who are employees of Disney, which is local to my area. And Disney employees have really taken advantage of that.
What they're doing is they're saying, if you want to keep getting coverage for this, you need to register on our proprietary app, and you need to check in at least 4 times a month, tell us your weight, log meals, go through weight loss counseling exercises in the app, and switch the pharmacy that you're using. Get it through our mail-in pharmacy, Cigna's mail-in pharmacy, Express Scripts, instead of whichever pharmacy you choose. I mean, they're exerting a lot of control here, and introducing a lot of additional hoops to jump through.
I think it's called the Omada app, and it was funny. I've never used it, right? And so, I actually asked one of my patients who's affected by this, and I asked him, "Oh, have you used the Omada app before?" And he's like, "Yeah, I used it 6-7 years ago." And I was like, "Well, what's it like?" He's like, "It's like a day in 8th grade health class, Essentially, it's like eat better, move more, those kind of platitudes that people struggling with weight loss have been receiving for, the last 50 years.
Yeah. On one hand, it's stupid, right? It's like a driver's ed course when you get a ticket, and you're frustrated. You got to go next, and take the test at the end. On the other hand, it's really intrusive. I mean, they're going to be collecting significantly more data on all of these patients.
I didn't even consider that.
We would expect they will absolutely parse that data in the future and find some way to use it against their subscribers, right? Their members. When you use the app, it's going to ask you, are you losing weight or not? And if you say yes, well, maybe that's going to mean that you shouldn't get the meds anymore because you've met your weight loss goals. If you say no, I'm just maintaining, well, then maybe that's going to say, the weight loss meds aren't working. So you can see them making an argument regardless of what the data shows. You can see that they're having now all this ammunition to just be capable of making a stronger and stronger argument that this segment of the patient population doesn't deserve GLP-1s.
That's such a great point, Andrew. Yeah, I actually have a patient. I treated her with Wegovy, I think, basically when it first came out. I can't remember if that was 2021 or 2022, but in that period of time, she's lost like 150 pounds and has maintained it. And, no longer has blood pressure issues, no longer has blood sugar issues, no longer has sleep apnea. And now there's been a lot of pushback saying, well, why are you prescribing this to her? At least in her last practice, there was a lot of pushback saying, hey, why are we, going to continue prescribing this to you? You're a normal weight. The argument is that's like telling someone with high blood pressure, you start on some blood pressure medications. Well, your blood pressure looks great. Why are you taking these medications? You crazy?
Get off your antihypertensive. Yeah.
I do see it the same way. I could definitely see the risk there. Now, I will say one thing. While we make fun of things like the Omada app for it's kind of like, it's almost like Mr. Mackey from South Park.
For South Park, yeah.
Processed food's bad, okay? But in all seriousness, one of the things I have been concerned about a little with these medications is that people see it as a substitute for the important lifestyle changes. In fact, back when I was in like a corporate practice, I would make my weight loss patients check in with me every month. Like I wouldn't just prescribe it to them 3 months at a time or 6 months at a time, because I wanted to, at least hammer home, and ask them about these areas of their life. Like, hey, what's your diet been like the past month? Exercise patterns, movement patterns, kind of give them goals, for the next month. And that's where I'm interested to see, like, because I'm going to make the assumption that the average person who is taking the medication is not making much in the way of like serious lifestyle changes.
Right.
At least not as it's intended to be. Like they're probably not meeting the 150 minutes per week of exercise minimum, et cetera, et cetera.
Guaranteed, right? I mean, the medications make it easier to eat less. They don't change, whether you're eating hot dogs and brownies all day or not.
It does beg the question if like the other kind of obesity-related conditions like heart disease, diabetes, metabolic disease are not tracking downwards, does it kind of call into question the utility of these medications? I don't know. What are your thoughts?
The events of heart attack, right, are down.
I'm not aware of any data that suggests that cardiovascular disease is down since GLP-1s. There's something to look into.
I thought there was data that showed that within the population that took GLP-1s, they had fewer cardio events.
That's a single trial. Like whether that's applicable.
So you're saying that trend may or may not hold in other cohorts or across the board.
Yeah. And with a medication that's expensive, it matters, because if we see, for example, this really substantial decline in heart disease and diabetes and metabolic syndrome and all-cause mortality, well, then it really does pressure, for example, Medicare to start covering these medications, because right now Medicare does not cover GLP-1s.
There's big news on that. This just came out yesterday from the Trump administration. This huge news.
This is a perfect lead-in.
I was going there one way or another. We were going to be led into it. Like
nice.
The challenge with so many of these things is the news announcements, the press releases are ahead of the details. The detail that's been released so far is that the Trump administration is saying they've reached a deal with Eli Lilly and Novo Nordisk, and Dr. Oz, as a part of his leadership of CMS, I think, they're saying Medicare will cover these GLP-1 medications starting next year. You can pull whichever version of this you want. There's a CNN version. There's a Fox News version. I pulled the Axios version. This came just yesterday. The Trump administration announces Medicare coverage for weight loss drugs. There's a lot here. I want to be clear that there's not a lot on paper yet. There's been a big press release. There's been a big news conference about this, and there's a lot of information still to come. But some indications are that people on Medicare who have obesity and a comorbid condition will be able to get it for a $50 copay next year.
Wow. I'll point out that they sort of moved the goalpost a little, which I actually think is a good idea, particularly in this case. The FDA approved indications for these GLP-1s are actually anyone with a BMI of 30 or greater, or someone with a BMI of 27 to 29.9 with a comorbidity, which basically you could find a comorbidity in anyone.
They've moved the goalpost a lot, to be clear, right? Like this is now, it looks like if this detail is accurate at this early stage of them, announcing it, it looks like you'd have to have a BMI of 35 or greater and have another, comorbidity. That's quite a bit different than 27 or more with another comorbidity.
Can I tell you why I like this? Here's the thing. We've talked about, I think in the past, this concept of the obesity paradox. There does seem to be kind of a sweet spot that is sort of in the BMI range of overweight to maybe slightly obese, where mortality actually drops. I don't know if we could pull up a
obesity paradox curve. It's this phenomena that if you have a little bit of extra weight, it actually helps your survival when you get sick.
We'll pull up the graph, and I want to make it clear that this is not as simple as a graph. Like there's a lot of studies looking at obesity and weight loss and health outcomes, and there's conflicting results. But there does seem to be this global trend where having a little extra weight is not necessarily a bad thing. And where I think this is most applicable is senior citizens. For example, if you have someone with a BMI of 28 and like high cholesterol, having them lose weight with the GLP-1, particularly if it's rapid weight loss, which oftentimes happens, is not necessarily good if you're in, that 65 plus population, because what we have definitely seen in the trials with the GLP-1s is you get a decline in muscle mass that's pretty significant. Yeah. And on top of that, bone density is another thing that can decline with weight loss. And these are two things that are real issues in the elderly: frailty and then hip fractures, right? Someone who gets a hip fracture has a really high chance of dying or being permanently disabled afterwards. We see things like weak grip strength being directly correlated with the development of dementia. Now, I'm not saying that's necessarily causal, but it does, sound some concern for rapid weight loss in the elderly.
Basically, there's a ton of literature on this. It seems to have evaluated lots of different cohorts. I think the broader observation was made, right, that people who are overweight have higher survival rates.
So that's the obesity paradox we're kind of talking about, where, on the left-hand side, you have your hazard ratio. Higher hazard ratio means the higher likelihood of death. On the bottom, you see the BMI as it trends upwards. And you see, as you reach the extremes of BMI, like upwards of 35, there's absolutely a significantly higher mortality rate. Oh, and again, this is global. This is not looking at the elderly population. But you see right here, this valley of lowest mortality is just a little bit of overweight.
Even just a tiny bit obese there. Yeah.
Yeah, exactly. So there can be harm in overtreating is what I'm getting at. So I'm actually in complete agreement with this Trump proposal, which is something that's not often said.
If we look at a chart like this, we're saying like the announcement from the Trump administration about coverage that's been negotiated for GLP-1s is kind of targeting the most at-risk population. Yeah, is that exactly part of why you think it's
targeting the most at-risk, but also removing the risk from those people, particularly your BMI of 27 to 29.9, like it in a way almost protecting those people, because sometimes people want what's not good for them. You know what I mean? I know that sounds super paternalistic,
Yeah.
But like, a patient will come to you and say, oh, my BMI is 28 and I want to be a normal BMI. In some cases, the doctors think this is a great idea. In some cases, the doctors, no, it's not necessarily a great idea, but like, the patient wants it.
Mhm.
This kind of removes some of that conversation in a way. And I know I'm never like necessarily in favor of restricting access. But in a large scale program, you do have to
Yeah.
consider these
I
things.
mean, I feel like it's worth pointing out that you're getting at the heart of this tension in medicine, right? It's like we want individual patients to be empowered to pursue optimization largely to whatever extent they want at their own individual responsibility, and yet when the taxpayer is paying, when everyone's paying, we want to make sure we're doing something that is the most efficient for everybody.
Yeah, and not only most efficient, remember, we're also looking at large collections of human lives.
We want to make sure policy is saving the most lives.
Yeah, and also, again, protecting lives. Because remember, although our practice, we run a smaller practice that allows us to really tailor to the needs of a patient.
Mm-hmm.
Larger scale practices are not necessarily doing that. So, for example, if we have someone who is in that BMI of 28, maybe wants to lose a little weight, heard about GLP-1s. Well, we can use, a compounded alternative to do kind of like a microdose for them. So they'll kind of get the cardiovascular benefits, maybe some of the longevity benefits, but not as aggressive with the weight loss. But, when you're using Wegovy, it's on a ramp, right? People just ramp up according to the schedule, and it's sort of a one size fits all plan. And that may not be the best for populations.
I want to be careful not to bury the lead. Like I think this Trump announcement, if they're able to get details out soon, and if it sticks, it generally looks like it will at this point. It looks like it's about to change the landscape tremendously. Like it could significantly increase the number of people that are on these medications,
which should drive down the cost of these medications substantially.
That's part of the ambiguity that is at the heart here. There's some of the reporting says that they've agreed to cap the cash cost of the medication in the $300 a month range.
Is this all doses?
Sometimes they mention that it's of the lowest dose, which is not particularly helpful. Other times they mention it's of any dose. So again, this is where I'm really anxious to see more details in the reporting about this. So Eli Lilly will offer the $245 monthly price for GLP-1s to all 50 states' Medicaid programs, and states will have the ability to opt into this price. This is going to affect Medicare. This is going to affect Medicaid. Those are huge covered populations. There's negotiation here that we don't have oral GLP-1s today that are very effective, but there's negotiation here that once a future oral GLP-1 weight loss drug is approved, that it would be available for $150 a month. And again, they don't quite clarify like which population will get it for $150 a month, but I think that is the negotiated rate that Medicare will pay.
Do you think there are any states that would opt out? Like, do you think any, like, because that would be such a politically unpopular opinion.
Yeah, good question. Yeah, I don't know.
There was all these states that opted out of Medicaid expansion with Obamacare.
I mean, this is where the details matter, right? Like, you could imagine that Trump's going to tie it to some sort of anti-DEI stance, and he's going to say, like, you get the cheap GLP-1s, but you gotta take some hardline conservative position on gender identity. And
it's so funny because it would be telling to see how serious people who were serious about those initiatives were when they have to like trade between their obesity medications and their principles.
Exactly. I want to just linger over just a couple more of the big level details. They're saying 10% of Medicare enrollees will be newly eligible for coverage. This starts, we're expecting the middle of next year, so it's not January 1st to my knowledge. So again, everyone on Medicare, but who meets the conditions? So, BMI of 35 plus, et cetera. This is a very huge like earthquake and shift in coverage. There's a lot of different price points mentioned here. There's $150 as the negotiated price of a yet to be released, yet to be approved weight loss pill. there's $50 quoted as the copay for people on Medicare who are anticipated to receive coverage next year for this medication. There's $245 a month, which is what appears to be, they're saying, is the cost that the manufacturers have agreed to bill Medicare and Medicaid. Drugs will also be available for cash pay on Trump RX starting no later than January for $350 a month.
It's called Trump RX.
Yeah.
What is Trump RX? I'm just curious.
It's the one where he's going to reduce prescription rates by 1,000%. Remember? He's been announcing that he's going to reduce the cost of prescription medications by 1,000%. This is Trump RX. Find your medication for the lowest price, coming soon.
I got to say, calling it Trump RX is like Obamacare referring to it as the ACA as Obamacare. Like,
Right.
I just find his level of narcissism funny at times.
We'll call it pride. His level of pride is astounding.
You're right. And his pride in his work.
His pride is pretty high. Yeah, his self-esteem is. If we could bottle Trump's self-esteem and give that as a antidepressant drug, that'd be great.
I would pay $1,000 a month for that. No questions asked. I'd probably give myself twice the recommended dose.
Trump esteem. Yeah, so, Trump RX is this, like, basically it's a press release and a cute website and an executive order, and nobody knows what's going to come of it. I think every possible interpretation is open to debate because we just don't know. This is an official website of the U.S. government, whatever that means. It is a .gov. It's trumprx.gov. And again, I'll go back to, there's the reporting, which is light on details, but high on like highlights, says that you could get these GLP-1 drugs cash pay starting next year for $350 a month or less, and that over a course of 2 years, it will be trending down to $245.
Is this all comers? This isn't just the Medicare.
That's what it says. It says the drugs will also be available for cash pay on Trump RX.
Okay.
I read this in another news outlet first. So this isn't just Axios. These are the highlights of the press conference. I think what's yet to be determined is all of this in writing, in policy, and in execution. The highlights are quite exciting. It portends a world where there's significantly more access and significantly lower cost. I'll argue with you for a second because I've personally lost 65 pounds on GLP-1 drugs. Let's go a little hypothetical. I did lose weight, truly. And hypothetically, my diet is brownies and hot dogs, ultra processed meats and refined sugars.
Ultra processed sweets.
I eat a gas station diet of brownies and hot dogs. If my diet of brownies and hot dogs goes from a lot of brownies and hot dogs to a little bit of brownies and hot dogs, such that I'm losing weight or maintaining a healthy weight, is it bad that my body is like rebuilding itself from all that hard pickleball workouts with just brownies and hot dogs? Probably. Even if I don't make underlying lifestyle changes, right? I want to get at this kind of like paternalistic vein of thought. Like, I think everyone's better off making lifestyle changes and getting to a healthier BMI. But aren't I better off, hypothetically, even if I made zero lifestyle changes, aren't I better off at a lower BMI?
Yeah, not always.
Not in 100% of cases. And there is such a thing as too low of a BMI, for sure.
Yeah. The counter argument would be, my father, who is, octogenarian.
Which means he won the Olympics. Is that right?
That means he won the game of life because honestly, no one expected him to make it into the 9th decade of life.
So he's in his mid-80s here.
Yeah, mid-80s. And he's someone who had, 5-vessel bypass at the age of 55, I think. So not too much older than me. He's still around with us, largely because he did make some significant lifestyle changes, but also thanks to the, Big Pharma. Let's shout out to Big Pharma. They are right sometimes,
I want to know who did that 5-vessel bypass surgery and which medical products are in your father, because those are clearly deserving of medal at this point.
Shout out to Shands Hospital in Gainesville for, I don't know the name of the doctor, but they did a great job. It was interesting because very recently his doctor had put him on a GLP-1 semaglutide. It was the oral one. It was Rybelsus. And he did lose quite a bit of weight, but it wasn't intentional. It made him feel sick all the time. He was actually starting to look frail. And so I actually told him just to stop it, and he did. And he feels much better. Like his GI symptoms are gone. He's put on a little bit of weight, but he feels a lot better. So again, it's not always restricted, but yes, let's take it specifically your case. I would agree, on a lot of levels. One, clearly you are in much better health than you were, 3 years ago. I would also argue that you have implemented lifestyle, like the pickleball is kind of a new thing for you.
I for sure have. I think I just, on behalf of all fatties, there's this interesting phenomena in medicine I've learned about through working together that, once you have a diagnosis, many of these diagnoses you get to keep. Like if you're diagnosed with diabetes and you get your blood sugar under control and everything, you get to keep that diabetes diagnosis forever. I think I get to keep my obesity diagnosis forever. So as an obese person or a person with an obesity diagnosis.
Person with obesity.
Person with obesity. That's right. A human. I just think, I just think for all those, I'm just broadly in favor of expanding GLP-1 access. And even for people who are unwilling to make lifestyle changes, I hate that Cigna app. I hate that Omada thing.
I do too. I mean, we're on the same page there. I mean, because that app is clearly nonsense, and it's clearly just there because some people are going to forget to do it, so they don't have to extend coverage to those people.
Right.
It's a gatekeeping measure, and I think it's ridiculous.
If they can use that app to deny one refill or delay one refill, to each patient once a year, that's a huge savings. Huge, right? I mean, it's just a game of numbers. It's like, let's do the app. Let's make sure the app is like just unpleasant enough that some people forget to do it once a month. It's very manipulative. And let's be clear. I know I mentioned this before, but it really gets in the way of the relationship that is supposed to be the care relationship that's supposed to be between a doctor and the patient, and instead now inserts this third-party app to tell you whether or not you deserve your GLP-1 medication that your doctor says you need.
Exactly. And to the crux of your question, there's so many medications that we prescribe to overcome bad lifestyle choices, blood pressure medications, diabetes medications. And I will point out that a highly processed diet seems to be the diet of choice for highly successful people, such as Donald Trump, Elon Musk, and yourself. So there may be something to it that it's actually somehow feeding the brain and making you guys more capable.
It leaves more reserve capacity for other endeavors, not processing the food. I don't know that any of those people, myself included, are poster children of health, but
Trump is 84, right? Isn't he? And he looks great. I mean, really, he does. I mean, for someone
he golfs every day. He's
how old is he?
He's 79. We owe him an apology. He's not even 80 yet, but he is in great health for 79, to be clear.
I've seen a lot of 79-year-olds in my career. And yeah, I mean, as 79-year-olds go, he does look good. Now, I do have one other question about this, which is, because Medicare tends to be the trendsetter, is there anything about that talks about whether commercial insurances are prone to follow suit?
I haven't seen any factual reporting on that subject. I've seen some speculation. It's worth speculating that if the cash cost of the medication is now driven to $350 or less, that it's going to completely change the calculation for insurance companies to cover it. It is yet to be determined. And that's why I said, this is a massive earthquake, a massive tectonic shift in the GLP-1 world, or it is reported to be. We need to see the details.
It leads to a perfect kind of follow-up to this podcast that, some of these questions that we've brought up that we should, bring up in a future podcast because they are really fascinating.
Any other Ozempic news or any other things you're following in the news before we wrap?
I was going to bring up a whole thing on the telehealth laws.
We should cover that next. Yeah.
I think that's worth a whole episode. So I think I'm going to save that for the next one.
Dr. Dave, thank you as always for your time.
It's been a blast.
We'll chat soon. Cheers.
Chat soon.
Thanks for tuning in to another episode of the After Hours Clinic podcast. Make sure to subscribe to the show on your favorite podcast platform so you never miss an episode. And if you love the show, leave us a review. You can sign up for our newsletter at joinbetterlife.com, and feel free to send in your hot takes and medical questions to podcast@joinbetterlife.com. Disclaimer: this podcast is for informational purposes only and does not constitute medical advice or establish a doctor-patient relationship. Content should not replace professional medical consultation. Always consult your healthcare provider for medical conditions. Do not disregard or delay seeking professional advice based on podcast content.